Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
So thank you for having me. This talk is going to sort of touch on cancer and sleep in general, because my experience is that sleep problems can certainly emerge in the setting of the diagnosis of cancer or treatment thereof. But oftentimes what we see is people who have some sleep problems or intermittent sleep problems prior to diagnosis and treatment. It tends to get a lot worse, but the problems are still the same. And so whenever I see someone who's actively struggling with whether it's cancer or any other disease state that seems to be the cause of the problems, I always dig a little further, and I would say 95% of the time, there are issues that existed prior to. So I kind of like to take this talk. First, we'll touch on the overlap in sleep and cancer, but also just to talk about sleep in general, because I think all of the points that I'm going to touch on are applicable irrespective of the state of what disease that you're dealing with or just in day-to-day, night-to-night sleep. So I have no disclosures or financial relationships to disclose. So this talk is sort of broken up into several parts. First, we'll just talk about sort of the importance of sleep and how that is such a critical part of health, wellness, and management of disease in particular. How cancer potentially impacts sleep, and then really optimizing your sleep and sleep practices, which are kind of, to me, that's not entirely accurate. I mean, certainly we have behaviors about sleep, but then we're going to touch on sort of other aspects of it to think about where sometimes biology dictates behavior. Then emphasize, I think, with this is really talking with your healthcare team about sleep issues in particular. A lot of patients who I see who struggle with sleep for many years just sort of accepted it as being, well, that's just what it is. And more often than not, that's not the case. And oftentimes if you approach your healthcare provider for help and resources or referrals, you can find that things can get a lot better. So briefly, let's just talk about the importance of sleep. So I think it kind of goes without saying that sleep is important. And we all know that if we sleep better, we generally feel better. And there's lots of data and evidence to support this notion, not just our own experience, but rather there's multiple studies that sleep is an important and critical regulator of mood and mood regulation. And in fact, depression and anxiety can be caused by sleep loss or sleep deficit. And we see improvements in both of those things. And there's a very reciprocal relationship between sleep and mood disorders, where that, poor sleep makes regulation more difficult or more impaired. And then difficulties with mood regulation or anxiety then make sleep worse. And then you have this reverberating circuit of negative feedback where they continue to make each other worse. Cognitively, and again, all of this is sort of, we have more cognitive resources when we sleep better. And that's both from the standpoint of memory, recall, decision-making, processing, focus, attention. Sleep is such a critical part of regulating that part of our cognitive function. And so there's just another piece of it, which is where the emphasis on sleep should be so important. And we really start to think about sleep. Historically, sleep was one of these things that was just sort of state of sort of inertness. Like the switch would turn off and our bodies would just stop overnight. And then the next morning we would just turn it on, right? And now over the last, let's say 30 years plus, we're starting to recognize that sleep is not just an inert state, that is a critical part of the regulation of our physiology. and that sleep is critical to the functioning of our waking cells. And so understanding that that includes our immune regulation, our endocrine system and blood sugar regulation, appetite and dysregulation of hunger cues. We have abnormal secretion of hormones, like food-seeking hormones, and hormones that regulate satiety. When in settings of sleep loss, these hormones become dysregulated. And you may notice that when you sleep poorly, you end up eating a bunch of junk that you would not necessarily ordinarily eat, or at least your cravings for those things are higher just because of this dysregulation of these hormones. So there's a lot underlying a lot of our behaviors are actual biological changes that are driving those behaviors. And we don't necessarily correlate those things. But in fact, some of the things like just grazing when you're not hungry, or going and passing a jar of candy and normally maybe walking by it, not even noticing it, but then kind of like, and just grabbing a few pieces, there's actually probably a hormonal component to that that's actually driving that and causing a little bit of the craving and or sort of, let's say, appetite dysregulation. So sleep problems are fairly widespread in patients with either diagnosed with cancer or with treatment of cancer. Studies have shown up to 75% of patients who are undergoing treatment for cancer have sleep complaints of some sort. And 46% reported that they were moderately to severely concerned with their sleep problems. In a survey, I can't read what that statistic was, but that's a pretty large percentage. I think it was, I don't know, it was 38%. Some were reported insomnia complaints. 28% reported excessive daytime sleepiness. 41% reported restless leg syndrome. And if you don't know what restless leg syndrome is, be glad, because it's a miserable condition. It's got a silly name, so I think it really does not do justice to the debilitating nature of this condition, but it is truly, it's a neurological problem where you have abnormal sensory output. And usually the International Restless Leg Study Group criteria for this diagnosis is it's an uncomfortable, unpleasant sensation in your legs. It's worse at night than during the day, better with movement, worse when sitting still. There's a lot of things that can kind of simulate that, but when you experience it, you know what it is. And when you have a severe case of it, it is horrible. Part of the reason there's probably a fairly large percentage who report restless legs is that it is thought to be a disorder of iron metabolism. So when you are iron deficient, restless legs tends to really kick up. Iron deficiency anemia is fairly common in patients undergoing cancer treatment. And so it's probably that overlap between those two things. So when I saw that stat, it didn't really surprise me, because in the general population, it's more like a 5 to 10% incidence. And then 48 of total prescriptions written for cancer patients in this 1,000 patient survey, 48% of prescriptions were for sleep. So you can, just by virtue of that statistic alone, tells you how widespread sleep problems are in patients that are going through cancer. And then 18% reported a worse quality of life related to sleep disturbances than the national average. So obviously sleep is something that is generally negatively affected by cancer treatment, for sure. It makes it harder to really cope with it. So what are some of the sleep disturbances? Well, the things that I see every day, patients who have trouble falling asleep, patients who have trouble waking up and not able to fall back asleep, waking up tired, feeling sleepy during the day. With that, you have cognitive issues like difficulties focusing and concentrating. Early morning awakenings are sort of just a different sort of presentation of a middle of the night awakening. It just happens to be that you don't ever go back to sleep after that point. And then there's sleep apnea, which is snoring and breathing or abnormal breathing or gasping during sleep, which in and of itself is also extremely widespread in the general population. 1 in 5 patients 1 in 5 adults in the United States have some degree of sleep apnea. Over the age of 70, it's estimated about 1 in 2 people have some degree of sleep apnea. So that is just another disorder that's widely prevalent that is sometimes not recognized and even maybe asymptomatic of it from a sleep perspective prior to treatment for cancer. And then once treated, you become more and more symptomatic of it. I see that all the time where patients will come to see me and I diagnose them with pretty severe sleep apnea, but they didn't really have trouble with sleep or being tired or sleepy until after they were either being treated for cancer or had a major surgery or some major illness where they become profoundly symptomatic after. And that sleep apnea was there years and years and years prior to their presentation, but rather they became symptomatic of it once sort of how I like to look at it is sort of there are certain reserves that we have that allow us to cope and compensate with certain things where when our bodies are essentially being compromised, we become far more symptomatic of these things. And that is also, we see that with just age. As we start to get older, we become more symptomatic of things that we may not have been symptomatic of when we were younger. So look for changes in your patterns. I mean, that's a simple way of looking at it. If you notice that you're sleeping poorly and it was not your historical norm, and then you're more tired, well, I'm getting chemo or I'm getting radiation, of course I'm tired. Well, yeah, of course, that is a component of it, but if your sleep has changed, in addition to that, it may be exacerbating whatever fatigue or sleepiness or problems with sleep that you may have. You have a question?
How do you know if you have sleep apnea? I mean, if you sleep alone, how do you know?
Well, if you have increased fatigue, tiredness, if your sleep is compromised, if you don't have a bed partner but family members or other people have in the past said you snore like a freight train, that is a sign potentially. The volume of snoring is a direct correlate or a predictor of sleep apnea because the volume of snoring, sleep apnea is essentially our throat relaxing. And snoring is the first step towards the development of that. You can snore and not have sleep apnea. It's rare to have sleep apnea and not snore. And so if the volume of snoring is reflective of a degree of collapse of your throat, essentially. So the louder the snore, it means there's more tissue collapsing and vibrating. And so that in and of itself, and then but you can have sleep apnea and have sleep problems, right? So it's been estimated somewhere that you heard the numbers I just reported in terms of the prevalence of this condition. Some older numbers, I think it's less than it's become more recognized, but the previous upwards of 80% of patients with sleep apnea were undiagnosed. This was, that statistic was about 10 years ago. I think it's probably more like 50% now, if I had to guess. It's not based on any current data, but point is that it's remarkably prevalent and often overlooked. So how does cancer impact sleep? Well, it's lots of different ways it can. The way that these symptoms may manifest is fatigue, daytime sleepiness, and we'll talk about the difference between fatigue and sleepiness. Disorganized sleep-wake pattern, so your sleep in bits and starts, you nap during the day, you sleep for a few hours at night, wake up tired or not refreshed, or you wake up refreshed and you get profoundly sleepy within a few hours. That is not necessarily just because of cancer treatment. It could be because of more problems with your sleep. And then obviously insomnia, which could take the form of trouble falling asleep, staying asleep, or back asleep, or like wakes. So how cancer impacts sleep? Well, treatment and medication side effects, hospital stays, we'll go through each one of these sort of by slide. Pain obviously can impact sleep, and there's a reciprocal relationship there we'll talk about. And the fatigue and then mental health, and so whenever cancer is a profound psychological thing to deal with, which you all know. And you can have perfectly, let's say, stable, no mental health issues whatsoever. And then you get this life-changing diagnosis. And to me, in my view, it's if you're not struggling with it from a psychological perspective, I think you're not paying attention because it is profound. And invariably I would expect there to be some degree of impact on your overall well-being from a mental health perspective. That's just coping with this life-altering diagnosis. So certain medications certainly can impact your sleep beyond. The chemotherapy, radiation, all of those things certainly can cause problems with sleep or wake and fatigue and other symptoms. But there's other treatments that can have a negative effect on your sleep. Certain medications that you're prescribed, even daily medications that you may be chronically taking, blood pressure medications, diabetic medications, medications for asthma. These are all things that can potentially impact your sleep. And again, you become more susceptible to the effects of these things potentially when you are in this undergoing treatment specifically, because your body's more compromised essentially. And so you have less reserves to deal with these things. Anemia is, we touched on that with the restless legs piece. That anemia really generally will cause more fatigue than sleepiness, which I have a slide following this, which I'll dig into that in a little bit. And then medications, even just that treat pain, like opiates, for instance, that can cause abnormal breathing, so it can exacerbate sleep apnea. It can cause a different type of sleep apnea because of the effects on respirations during sleep. But even in pain itself can obviously affect sleep. Nausea is yet a very common side effect of chemotherapeutics, of course, and that too can affect sleep. And the medications that you take for nausea can also cause excessive sleepiness, so maybe sometimes helpful for sleep, but not great for wake. I always tell patients the hospital is the last place you go to get rest. The environment, it's unfortunate, but it's somewhat a necessity, but early morning blood draws, vitals in the middle of the night, just there's constant disturbances. But beyond that, there's just potential for disorganization of your sleep and wake because you sleep so poorly at night. You're then sleeping off and on during the day, so then you can't really fall asleep at night. And then you're just falling asleep, and the nurse comes in to take your vitals, and then you wake up and you just fall right back asleep, and then they come in to draw your blood. I mean, it's miserable. So what can you do about it? Well, there's not that much you can do. It's just is basically try to get out of the hospital as quickly as you can. But it's sometimes an absolute necessity. But trying to differentiate night and day, right? So. And this is harder in the ICU because there's no windows and there's not they try to turn on the lights and turn down the lights and so forth. But if you can try to maintain that sort of light day-night kind of cycle, it does at least help reinforce, because these external light is the most powerful. The term is called Zeitgeber, which is a German term for time-setting cue. And light is the most powerful time-setting cue there is, and it has an alerting effect and a stimulating effect. It sends a signal to your brain that, okay, it's wake, it's day, and at night, dark. You should generally sleep in a dark room, but trying to maintain that does help reinforce some of the backdrop of the biological cues for sleep and wake. But there, again, the hospital is a tough place to try to preserve your sleep, just by virtue of the circumstances. There's lots of different sources of pain or potential types of pain that patients with cancer treatment or have cancer, which in and of itself can have its own effects on sleep and needs to be managed appropriately. And no one wins an award for courage for struggling with pain. And so it's often people are somewhat sometimes reluctant to really more definitively treat their pain. But in the setting of cancer and treatment therein, sleep is such an important part of part of our body's sort of healing. The immune regulatory piece to things is a critical part of it. And so having adequate pain control, period, just for your quality of life while undergoing the circumstances is such a critical part of your overall well-being. But beyond that, if pain is affecting your sleep, you're having a negative effect on your body globally, and potentially even impacting your recovery or response to treatment. So it is important to be vigilant about pain control, not to try to withhold your reports of discomfort and pain when it is poorly treated to your caregivers. And it sort of speaks for itself, but I think that's something to important to emphasize. So, we think that it makes sense that poor pain control or pain itself interferes with sleep. And yeah, duh. But if you look at the literature, it's really interesting in that the relationship with pain and sleep is actually profoundly stronger in terms of poor sleep causing worse pain, way more so than pain causing poor sleep. And when you are sleep deprived, it creates a hyperalgesic state. What that means is if you have a pain source, your brain's interpretation of that pain is going to be profoundly higher when you have sleep deprived than when you are well rested. They did these really elegant studies. They took these probably college kids and they took basically a heat source, essentially a lighter, and they put it under their hand and they, timed how long it was before they pulled their hand away, right? And they did it after an adequate night's sleep and then after a night of sleep loss. And the subjects pulled their hands away twice as fast after a night of sleep loss as compared to when they were well rested. And so that was just a clinical example of how hyperalgesic, how our brain's interpretation of pain signals is going to be much higher and much more pronounced when we are sleep deprived and when we're well rested. So fatigue and sleepiness. So fatigue is a lethargy and a listlessness, and you just got nothing. It's hard to get up off a couch because you just feel like lead. Sleepiness is defined as the tendency to fall asleep in sedentary or unengaged, overwhelming need to sleep, or the ability to fall asleep when given the opportunity. If you are sleepy and not fatigued, oftentimes, if you're active and engaged, you don't even notice it. It's when you sit down and you start to doze, because sleepiness and the absence of fatigue, activity is a countermeasure to sleepiness. So you won't notice it necessarily. So sometimes I'll have patients and I'll specifically sort of try to differentiate fatigue from sleepiness for them. And and they don't view sleepiness as a problem, but it is a symptom because every time they sit down, they fall asleep, but they don't really think of it as a problem because they don't have fatigue associated. Importantly, fatigue, when it is not originating from a sleep source, right? So sleepiness is a very specific symptom that emanates from some dysfunction in sleep or the sleep-wake mechanism or something going on there, whereas fatigue can emanate from 1,000 different sources. If you're fatigued and not sleepy, you won't fall asleep, right? And sleep will generally not alleviate fatigue when it is not emanating from a sleepiness source. So you can have both fatigue and sleepiness. And if you sleep, you wake up from it and you're no longer sleepy, but you're still fatigued. That kind of tells me this is not this source of fatigue is not emanating from sleepiness. And of course, anemia typically causes fatigue, not sleepiness so much, right? And so oftentimes I'll have patients who are anemic and they'll say, yeah, I'm tired all the time because I'm anemic. I'm like, yeah, you may be fatigued, but the reason you're falling asleep is not because of the anemia, I don't think. And I mean, there are caveats to all of this, but as a general rule, that's typically what we see. And most people with
I'm sorry.
No.
I was tested because I was having fatigue and I was tested for iron, but they also tested me for B12 and it turns out that I had a B12 deficiency. So surprisingly enough, I didn't expect that to be the case, but many people can be B12 deficient. I was severely deficient and I now give myself a monthly shot.
Yeah, absolutely. B12, sometimes vitamin D deficiency will cause that. And it's interesting. I mean, my wife's B12 deficient. I give her a monthly shot and she feels so much better after she gets her B12 replaced.
I think it makes me more energetic during the day so that I don't have sleepiness and then helps me feel more tired at night.
But the other piece of that is that if you're fatigued, you're less apt to be more active and engaged and do more. And so if you're sleepy and fatigued, you're more apt to experience sleepiness. But if you can reduce the fatigue component and stay more active and engaged, you may not notice the sleepiness as a problem because you're not as sedentary. So there's kind of a reciprocal relationship there. But lots of things cause, but treatments for cancer, from radiation to chemo to, a variety of the different medications that you may be treated with have the potential to cause fatigue and sleepiness in some cases. So 4 out of 10 patients undergoing cancer treatment indicate fatigue worse than the national average. And 50% of patients reported that they were moderately to severely concerned with sleep problems, of which fatigue is one. So we've kind of touched on all these points. But yeah, I also think it's important to note that the things that we talk about in terms of living a healthy lifestyle when you're not in the midst of treatment for cancer are doubly important while you are in the midst of treatment for cancer. And so that includes nutrition, it includes adequate sleep or optimal sleep, it includes exercise and activity to whatever extent you can engage in those things. But you know, all of it, fatigue makes our ability to tolerate everything harder, right? And so we are more apt to be more emotionally labile and have more swings in our mood and more agitation and irritability when we are fatigued. And sleep loss itself will certainly exacerbate fatigue, and in some cases, certainly in patients who have insomnia, what I like to call classic insomnia, they never get sleepy but are always fatigued, right? And so, and there's lots of reasons as to why that is the case, but sleep in that setting will help to alleviate their fatigue, because their fatigue is emanating from sleep loss and not from necessarily some other problem. So it's important to engage these things. And you know, the thing about fatigue is that it makes trying to motivate and or to exercise or do any kind of activity extremely difficult. But if you can engage in a certain amount of activity, and it's maybe a simple, 5-minute walk outside when it is not 100 degrees, of course. In and of itself, it can be profoundly invigorating, but also it's one of those things that if you don't use it, you will lose it. And with exercise, especially activities, especially as we start to get older, we decondition rapidly. And when you're in the midst of cancer treatment, deconditioning is almost expected, meaning you just do not have the reserves and or the physical conditioning to be able to. And so when I'm counseling patients about fatigue and how to manage it, the primary recommended strategy in terms of managing it is a graded exercise program. When I say exercise, I mean walk to your mailbox and back. Do that for about 5 days. And then if you can do that, now try to walk to your mailbox and then maybe 20 yards past your mailbox and then back. And do that for a week. And each time, if you do it every day, each day you will find that you start to have a little bit more, it's just like training. It just seems, to the mailbox, that seems silly. Well, no, not when your physical capabilities and conditioning will not allow you to do more. And if you push too hard and too far, it starts to have sort of a negative effect. You don't want to go to the point where it exhausts you, where that you are just a puddle for the rest of the day and can't do anything, because it almost has a reverse effect in that regard. So you want to kind of go up to that edge of where you are from a conditioning standpoint and not go too far behind that. Because if you have this profound exertional fatigue that then lasts it takes a day to recover, you're probably not getting benefits from it and actually maybe doing a little bit of harm in that regard. And you want to build upon what your base is. And that's people who have chronic fatigue syndrome and just chronic fatigue in general, that's sort of a general recommended approach. So you also, though, want to conserve your energy and try to save your energy for the thing, whether it's a walk to the mailbox or whether it is a trip to the doctor's office or whatever it is, depending upon the level of fatigue you're struggling with. You want to you have to be realistic, and you have to schedule your days relative to what your capabilities really are. And then, coping with fatigue is a whole nother piece, because you feel like you can't do anything. And there is this, meditation, there's cognitive strategies that you can help you, sort of just the coping piece of this. But it is a profound, debilitating symptom. And when you are in the midst of cancer treatment and you are overwhelmingly fatigued, it is absolutely, it's disheartening, and it kind of zaps your optimism because you don't feel like you can do anything. And so you have to be sort of realistic with what you can do, but sometimes it's like, go from your bedroom to the kitchen and back, if it's that level of fatigue. to try to maintain some level of activity, because some activity is better than none. So mental health problems, we touched on this. It's important to talk to your healthcare provider. Certainly your oncologists know and understand what it is you are going through. And they're not gonna necessarily be able to read your mind if you come in with a stoic face and never show any weakness, you're like, oh, fine, yeah, great, fine. You know, if you're struggling, it is important to have that discussion. Seeing a therapist in the midst of all this is, in my view, critical. Just in terms of coping with dealing with this type of condition, and all of the fallout from it in terms of the treatments and the side effects. So, 49% of patients undergoing cancer treatment were at risk for clinically significant anxiety, 38% were at risk for depression. So it's, these are, not unusual. And so your caregivers understand this and would probably want to hear from you regarding whatever it is you feel like you're struggling with. So let's talk about how to optimize your sleep. So this is I took this sort of from my general lecture on sleep in general. So sleep hygiene is, patients come to me, I do all the sleep hygiene things, it doesn't happen. Well, I could have told you that. And the reason we will tell you that is because sleep hygiene, which, let me come back to this slide. So, sleep hygiene, there we go, alone is not an effective treatment for insomnia, right? But it is essential means to maintain consistent sleep. And it is a critical part of all treatments for insomnia. But it is, in and of itself, it's not going to fix your sleep problems likely, unless it's just like, I'm drinking 3 cups of coffee before I go to bed, and I'm on my computer all night, and I'm, doing all the things you're not supposed to do right before bed. Aside from those things, even maintain the perfect environment. If you have problems, it's probably not going to be the thing that fixes it. But sleep hygiene, just to go back, more. Okay, more, go. So sleep hygiene is essentially, let's make sure our environment is optimal for our sleep. So have a relaxing routine before bed, and that for you is taking a warm bath, staying in a dim lit environment, trying not to activate yourself too much. People will always talk about a regular sleep schedule. Go to bed and get up around the same time. I do not agree with that statement. I think getting up at the same time is a critical part, or is useful in the sense that it anchors your sleep. But if you go to bed at the same time every night and you are not sleepy every night at the same time, you will have the same problems falling asleep every night. So my strongest recommendation for all of my patients is, if you are not sleepy, don't go to bed. Go to bed when you are sleepy. It is very difficult to fall asleep when you are not sleepy. And so the idea is that by maintaining a regular wake time, and we'll touch on this in a minute, your sleep should unfold relative to that wake time around the same time each night, if a number of other variables are also being addressed. So, caffeine, alcohol after dinner, some people find alcohol helpful, some people don't. Generally, it's not the best thing for sleep, helpful for staying asleep, falling asleep, not so great for staying asleep. If you're getting alcohol drip and have it continuously infused all night, probably would be more effective. Exercising before bed, patients will often say, well, should I exercise in the evenings? Only if it doesn't negatively affect your sleep. For a lot of people, you exercise at night and then you're pretty wound up for the remainder of the night, and it does affect your sleep. Trying to just basically do things that are, you gotta sometimes you have to figure it out for yourself what works best for you. But the idea is you want to try to create a sleep environment that is conducive for sleep. You want to try to not engage in things that are going to be overly activating right before you go to bed. Stimulus control is this idea that we want to decrease the arousal response to the bed and sleep process. And so it includes some of these things, which is sort of the bed is only for sleeping and for sex, right? Other than that, you really shouldn't be in bed. And part of the primary idea behind that is that if you spend your evenings or your days and evenings in bed, the bed becomes a place to watch TV, to read, to eat dinner, it loses the integrity of that for sleep. You know, if you don't get into your bed until you're ready to go to sleep, there is a psychological trigger where the bed is just this mushy, cozy place, and it sort of sets in motion that psychological change towards, okay, now I'm going to sleep. Whereas if you've been in bed for 2 hours prior to that it's very difficult to suddenly take your TV room and your dining room and all of a sudden flip it into your bedroom. And so it really does, it can for a lot of people negatively affect their ability to go to sleep. Again, my view is whatever works for you. So if it doesn't affect your ability to fall asleep, it's probably not a problem. But if you're having trouble falling asleep, it probably is. You know, go to bed when you're sleepy. The idea is, this is the hardest thing for patients to do. Most of my patients will not do this, which is if you're not asleep, this says 10 to 15 minutes, I usually say about 30 minutes, then get out of bed. Because now you're reassociating the bed or associating the bed as a place not to sleep. And so the idea is maybe you're just not that sleepy when you're going to bed. So get out of bed, read a book, wait to get sleepy again, get sleepy again, come back to bed. And that goes for middle of the night as well. It is helpful, it doesn't work for everybody, but it is something that helps to reassociate the bed as a place to sleep. You know, no pets in the bed, that does not go in my house. But if your pets affect your sleep, you should. Try to keep your room decluttered and try to keep it sort of, you know, make it a place that is for you, a place of you're freed from your waking life. I always like to say that the bedroom should be a sanctuary, and you walk into your bedroom and the rest of the world, the rest of your life should just disappear. And now you're in this protective cocoon where things can't penetrate. And part of that is creating an environment that helps to reinforce it. You know, dark room, cool room, these are all things that generally help people to sleep. So going forward with this, I like to think about sleep through a biological lens. We are taught to think that sleep is a behavior, and the same for everybody. Everybody should go to bed at the same time. Everyone should get up at the same time. Everyone needs their 8 hours. Everyone should be a morning person. And if you just follow the rules, you will train yourself to be a good sleeper. While true for some, not true for a lot of people. Reason for that is that conventional wisdom that we are all taught is incorrect, which is to say that sleep is not a behavioral process, it is a biological process. And so, and like all biological processes in the human body, there are differences amongst individuals. Think about your sleep through the lens of your biology. So the things you have to think about is first, what are your sleep needs? Second, you may not know this, but what's your sleep mechanism capability? Sleep is just a biological mechanism in our central nervous system. There is no biological mechanism in the human body that is not subject to some intrinsic dysfunction. And so some people the mechanism in and of itself is not robust enough to attain and or consolidate their 24-hour sleep requirements in a single nighttime sleep period. And we see this as a normal part of aging, which I'll get to in the next slide. The next is timing of sleep. And this is really one of my big focuses, which is our circadian rhythm. And we'll talk about that, this is governed by our biological clock. And then there's sleep fragmenting conditions and things that make sleep poor. So sleep needs vary. It can be normal in populations to have as little as 6, as much as 9 in some cases. And so thinking about sleep, you have to kind of figure out how much sleep do you need. And for each person, it can be different. But it's a critical part, which we'll talk about, but it's your sleep need and your sleep opportunity should approximate each other. So if you think about that, right? You have to think about, okay, let's say I go to bed at 9 o'clock most nights. And generally speaking, if I allow myself to sleep naturally or wake up naturally without an alarm, I wake up at 7, okay? So I have a 9-hour need. Or let me rephrase it. Let's say that it's a 9-hour opportunity. Let's say that I have a 7-hour need. Chances are pretty good I'm gonna be awake for a couple of hours somewhere, beginning, middle, or end. And what that tells me is 9 p.m. is way too early for me to be going to bed. Because chances are, if I go to bed at 9 and I'm sleepy, I will fall asleep and wake up by midnight or 1 and then be up for an hour or 2 before I can get back to sleep and basically take a nap, and then maybe take another nap, and then another nap, because I've gone to bed too early, because I've taken this opportunity, which is much greater than my need. 7-hour need, 7 a.m. wake time, I should be going to bed at midnight. Right, and so it seems like a duh, but it doesn't seem intuitive, because oftentimes people are sleepy in the evenings, and they look at this as a biological cue for their nighttime sleep period. Sleepiness in the evenings may not be a biological cue for your nighttime sleep period any more than sleepiness is in the afternoon. And oftentimes it's transient. Can't keep your eyes open for 9 to 10. You don't, maybe you doze in the chair a little bit, but after 10, you're wide awake. Okay, well, that's probably not the time you should have gone to sleep. And then go to bed at midnight, maybe fall asleep. So I can't tell you how many patients I have helped by just saying, you go to bed too early. You know, that's the consult, thank you. But that, it's so that's a really easy kind of thing to think about for yourself. Because almost always going to bed later will confer a better night's sleep. The notion that I'm gonna get a good night's sleep by going to bed early is a fallacy. And almost uniformly makes sleep worse. So sleep capabilities, as I alluded to before, as we start to get older, our sleep mechanism starts to wane in some terms of the robustness of it. We see it starting in our 50s and 60s, not to a large extent as we might in our 70s and 80s. But you can see this is what's called a hypnogram. And so what you see here is this is up here is wake and then light sleep, and then down here is, deep sleep, and this is dreaming sleep. And so what you can see is essentially there is you start out awake, awakening here, awakening there. So waking up at night is not abnormal. Waking up and being up for long periods of time is, but we all wake up 2, 3, 4 times a night that we don't remember. It's just brief as we're cycling through sleep cycles. But as you can see in this other slide, on the other half of the slide, you see there's far more waking periods, right? It's not that sleep needs necessarily change as we start getting older, but our capabilities of attaining our 24-hour sleep requirements in a single consolidated nighttime sleep period starts to wane. And so napping starts to become more of a accepted or normal phenomenon in that setting, just because you're not able to attain your 24-hour sleep requirements. I see this in young adults. I mean, so it's just it's process of elimination to figure out that this is the problem. But some people's sleep mechanism just isn't what it needs to be in terms of being able to consolidate their night's sleep. So I'm going to focus here for a minute on chronobiology and just or circadian rhythm. So chronobiology is the study of timing of biological functions. And so we have ultradian rhythms, which function within an 18-hour, under an 18-hour period of time. So our sleep, we unfold, go through a REM, a non-REM and REM cycle reliably when we're sleeping normally and without problems. Every night around the same times is following this regular pattern within 18 hours. Infradian rhythms are more than 24 hours. So the menstrual cycle is an example of another biological rhythm that's happening every 30 days. Pretty clockwork, and things are working should be. We're going to focus on circadian rhythm, which is what functions around a 24-hour period. We all have a clock in our brain. This is part of our biology. And this clock, we call it the biological clock, it's called the suprachiasmatic nucleus, but essentially it is what regulates sleep. It is, in my view, one of the most important structures in the human body because it regulates everything. So every cell in our body, and light is the most powerful stimulator and regulator of this clock. So when we go to Europe, we adjust to Europe time, but not because of the food or the smells or the wine, but because of light exposure or the Zeitgebers at certain times that adjust our clock, relatively speaking. So every cell in our body just about has clock genes. These clock genes turn on and off and determine the expression and activity of those cells. Takes our cues from this clock, right? And so when we are asleep, our cellular function is different than when we are awake. Cells together form organs, therefore our organ operations are functioning different because the cellular activity of those cells making up those organs are different at different times of the day and night. And Studies have demonstrated a higher susceptibility to cancer in individuals whose body clocks are misaligned with their schedule. Certain medications and chemotherapeutics have actually been shown to be more effective or less effective depending upon the timing of administration for this reason. Cell activity is higher, chemotherapeutic agents are more apt to be taken up more efficiently into the cells, and when their cellular activity is lower, it's going to be lower. So it makes sense that that would be a case. This is an area of science that is still a great intense study, but it is, and same with chronotoxicity, which is susceptibility for cellular damage because of exposure for the same reason, right? But so this is, I think what we'll see in the next decade is an explosion of an understanding of the chronobiology, the effects of medications, disease states, and treatments based upon our chronobiology and the timing of things. So, and again, just this is you don't have to get into this, but this is just looking at how our circadian rhythm affects our biological function to such an extent. So you can look at, this is thyroid hormone here. So you can see this is an individual who's sleeping normally. You see a peak in their thyroid hormone. This is someone who does not have a regular sleep-wake cycle. And you see there's dysregulation of the thyroid hormone production. You can see that growth hormone peaks here in a person who's sleeping normally. 90% of growth hormone is secreted in deep sleep, right? Here, you get very little growth hormone. So our circadian rhythm regulates our biological functions to such a large extent. But most importantly, it regulates our sleep. And so there's this idea of what's called the two-process model. And this concept I use literally every day for just about every patient when I'm evaluating. This idea is that we have these two processes. One is called the homeostatic pressure for sleep. The longer we're awake, the sleepier we get. And then there is our process C, which is our circadian drive to sleep, which is being driven by this biological clock. And these two processes are working in opposition. So another term for this two-process model has been the process oppositional model, where these two processes are sort of opposing each other. And so this next slide really speaks to what that is. This looks scary, it's not. And it's really interesting. And if you can incorporate this, you'll start to, my example of the 9 p.m. to 7 a.m. wake up in the middle of the night, this is why that happens. So as you can see up here, this is process S. So we start in the morning, it's 9 a.m. As the day progresses, our sleep drive keeps getting higher and higher. It reaches a peak, and while we're sleeping, our sleep drive drops, right? Were it not for an opposing process, we would need to nap every couple hours or every few hours, right? So we have an alerting signal coming from our circadian clock where it's opposing it and increasing its output in opposition and parallel with that process. And so you can see here that our alerting signal essentially is continuously opposing our sleep drive, and then while we're sleeping, it drops. And the reason it drops is not because we're asleep, but because of the timing of our sleep based upon our clock, right? And so you can see that our alertness level is going to parallel how much of our output of our alertness signal. So you can see here, this is where we sleep. We've already started to drop our alerting signal to allow our sleep drive to express itself. And then we sleep. And then while we're asleep, our sleep drive is dropping, our alerting signal is dropping, we stay asleep, and then we wake up and we do it again, okay? So the reason that's important is because something called circadian misalignment, meaning we are behaviorally sleeping in opposition with our biological rhythm. So this right here is what's called a core body, it's a core body temperature curve. And our circadian rhythms follow our body temperature. And so while at night our body temperature starts to drop, we get really sleepy, we fall asleep. While we're asleep, it reaches its low point. And during this period of time, it's extremely hard to wake up in the middle of the night. And if you are awake, it's extremely hard to stay awake, which is why it's been termed the forbidden zone, because a number of different major industrial accidents like 3 Mile Island and Chernobyl were based on human error that occurred during this forbidden zone. And so then as our body temperature starts to increase, we wake up, okay? So that is essentially the way it should work. Now, let's just say you are someone that's your biological clock, okay? But you have to be up at 3 in the morning, right? So you go to bed at around 7 p.m. So your behavioral bedtime. Okay, so first, you're gonna probably have some trouble falling asleep because you're not sleeping. Then you're finally gonna start to fall asleep, and then right when your alarm goes off, you are in your deep, deep sleep. So this is an example as why circadian rhythms cause problems falling asleep and or problems waking up in the morning. And it doesn't have to be 7 p.m. to 3 in the morning. If you're someone who's designed to go to bed at 2 or 3 in the morning and sleep until 10 or 11, but you have to get up at 6 or 7 in the morning, this is you, right? And so this is the most common thing I see literally every day is some variation of circadian misalignment impacting people's sleep. And so you kind of have to think about what's called your chronotype, which is are you a night owl? Are you an early bird? Not behaviors or choices, actually traits, largely governed by your genetic design. And night owls true night owls cannot train themselves to be morning people.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.